Hello and welcome to That Implementation Science Podcast, the show that aims to reduce the innovation to implementation gap to 16 and a half years. I'm your host, Mike Pullman, and on today's show, co-host Kevin King and I interview Katherine Rizzolo about their work with Lilia Cervantes on implementing policies to provide dialysis care in the undocumented immigrant population. We'll talk about how the experience of undocumented immigrants differs from those with citizenship without insurance, tools they used from implementation science in this work, the path to policy change in Colorado, and the role of implementation science in policy change. Implementation science, making common sense and decency incredibly rigorous. Today's show is sponsored by the Society for Implementation Research Collaborative, or CIRC, the world's premier implementation science professional organization. If you've ever said, "it depends," congratulations, you're ready for CIRC. Check out CIRC's website to see the resources they have available and consider becoming a member today.
Hello, everybody. Welcome to That Implementation Science Podcast. I'm Mike Pullman, and I'm here with my co-host, Kevin King.
Hey, everyone.
And we're really excited today to be interviewing Katherine, or Katie Rizzolo. Katie is an assistant professor of nephrology at Boston University's School of Medicine and is a second-year fellow in the Evans Center for Implementation and Improvement Sciences at Boston University. She won the American Society for Clinical Investigation Emerging Generation Award in 2024. Katie, it's so good to have you here. I'm kind of curious. It's early December when we're recording this. What are things like in Boston right now? What's the weather like for you?
That's a great question. We actually got our first real snow today. So a little bit of dusting on our car and some black ice. So I think it feels more like officially in winter now than before.
Yeah, you're hunkering down. How long will that kind of cold, snowy weather last? When do you get out of it?
I feel like that's a tough question in the current age, because I think 2 years ago was a pretty mild winter, but then last year we got more snow. So but typically I would say don't get comfortable. You're out of winter until May.
Wow. All right. That's a long time. Well, we're here today to talk about some of the work that you've done with Lilia Cervantes and others around dialysis care in undocumented immigrant populations. And I find your work just absolutely fascinating. I think it's highly topical, and I'm so excited to talk with you today about this. And maybe if we could just start by, why don't you describe to us what sparked your original interest in dialysis care in this population?
Yeah, sure. So, and I feel like my interest has largely been sparked by the interest of my mentor, Lilia Cervantes. So I'll give my answer. I actually started being interested in immigrant health first. I did my residency at Maine Medical Center in Portland, Maine, which is a great residency program. And they actually have a lot of refugees in Maine. And I got really interested in the immigrant population there, but wanted to do nephrology and was looking for a way to combine these two. And so I actually just typed into PubMed immigrant nephrology, and Lilia Cervantes came up just over and over and over again. And so she was actually in the middle of doing some policy work that I then kind of jumped into, and now we've collaborated a lot. But essentially, it was right up my field of what I wanted to do, looking at equity in the dialysis population for immigrants. And so would you like me to give a little bit of background there for maybe those who don't know that work?
Absolutely. Yeah.
Okay. So undocumented people, so people who do not have a current visa or documentation to be in the US, are not eligible for federal insurance. And this is really important because in the 1970s, Medicare actually created a special form of Medicare just for people with end-stage renal disease who need dialysis. So this really covers almost everybody who has documentation. So the minute you get switched to dialysis, you actually have a 3-month period, and then you can be eligible for Medicare. And that's how a lot of patients are able to do dialysis. But the undocumented community is very unique in that they cannot have access to these federal benefits. And so it leads to, I guess you would call it inequitable, but patchwork access to care. And so in some states, we did a study that came out in 2023 where we looked at each state and what their access to care was, because since federally they're not able to get insurance, it comes down to the state level. And we found in that study that there are 20 states that had statewide access, but that means that there's 30 that do not. And prior to 2019, Colorado did not have statewide access. And what happened there, it really comes down to the level of the city or even the institution about how they're going to be able to provide dialysis. The worst case scenario is something called emergency dialysis, which is kind of exactly as it sounds. It's dialysis only in the setting of being critically ill, which is basically sequelae of end-stage kidney disease. So high potassium levels, high acid levels, pulmonary edema, things like that. And it often requires an ICU admission. And so what was happening in Colorado prior to 2019 is patients were only eligible to get emergency dialysis. So they were often admitted about once a week. They would receive 2 sessions of dialysis. And this was like an institutional thing. This is just how they did it at this one institution. And then they were discharged. And as you might know, most dialysis outpatient is done 3 times a week. And so 1 time a week is just subpar. It led to patients having a lot of near-death experiences, feeling really terrible and much higher mortality. And so by doing the research I just described, patient experiences and looking at mortality and cost, Dr. Cervantes and her team, including me, were able to show that this was pretty deleterious. It was financially irresponsible, and it also just was really bad for patients, 14 times higher mortality at a 5-year period.
Katie,
So,
I want to jump in with 2 questions if I can. I think first, you want to remember that we're psychologists. So we understand that there's things like potassium and other, I don't even know what the other words you used were, but we may not necessarily be familiar with dialysis and why people need it and what that circumstance is. I wonder if you could first just briefly tell us, like, when do you need dialysis and what is it? And then I have a follow-up to that. But
Thank you for having me. Thank you for having me back up.
No, that's okay. Yeah.
So I'm a nephrologist, so this is a lot of what I think about every day. So with kidney disease, a lot of patients have chronic kidney disease, but when it progresses to complete kidney failure, that means that the kidneys, whose job it is to clean the blood, it's no longer able to clean the blood. When the blood can't be cleaned by the kidneys, certain things start building up and can cause problems. A big one is potassium. Potassium is one of the most dangerous ones because a high potassium level can stop your heart.
That seems bad.
That's bad.
Yeah, right. Okay.
The other big thing that I always say to patients that is a true emergency is you're unable to get rid of the liquids. So we all, we drink our coffee and our water and whatever all day long. But in a patient with kidney failure, they're unable to get rid of the amount of water that they need to get rid of, and salt. And all of that builds up. And when it builds up, they get swelling in their legs, but worse, they can get that swelling, that edema in their lungs. And they can't get rid of it because they're not peeing enough to get rid of it. And so that can result in a couple life-threatening complications. High potassium can stop the heart, or you can not be able to breathe because of the amount of liquid fluid in your lungs. The last one is high acid levels. And that's also just because your kidneys are supposed to be regulating these levels. And when they can't, acid goes up, and that can cause all sorts of problems. One is it can really be hard to breathe. So another breathing complication. So that's what happens. And so on dialysis, dialysis is kind of remarkable if you think about it. It's one of the only things we can offer that when an organ fails, we can actually keep you alive and you can go home. And so dialysis takes the place of the kidney. The job of dialysis is to maintain homeostasis. And what that means is maintain normal potassium levels, acid levels, get rid of fluid. And it allows patients to, survive despite the fact that their kidneys aren't working. Ideally, you've probably heard of kidney transplant. Ideally, patients get kidney transplants, and that is the best, but that's not possible for everybody. We just don't have enough transplants to go around. So often dialysis is what we're doing to keep patients alive who have kidney failure.
Right. And so it strikes me that when you're talking about this sort of policy where that people are prevented from getting scheduled dialysis because it's not funded, but then they have to go in for emergent dialysis, which, as you explained, like involves ICU admission and has all these other complications, but also has to happen regularly because their kidneys aren't working. Help us understand how that's paid for, because it sounds like it, like why would that be paid for at a policy level, but not the scheduled one, especially because a scheduled one seems like it would be cheaper. I think I'm
Sure.
confused there.
Yeah, that's a really great question, and actually kind of the crux of the policy change that occurred. So outpatient dialysis, as you said, chronic dialysis is paid for by the patient's insurance. Either they have private insurance or Medicare. And Medicaid often can supplement. If a patient needs to get admitted to the hospital to get dialysis and they are uninsured, the way it would be paid for is something called emergency Medicaid. Emergency Medicaid was created in the 1980s under the emergency, oh my God, EMTALA. I'm going to forget the name of it, EMTALA. Under EMTALA. And basically it says that no patient can be refused care despite if their lack of insurance if they have an emergency. And it's defined pretty generally. I can probably pull up the definition, but it's essentially like something that might kill you. So a complication that would imminently result in death if not treated, which would definitely be the case with not getting dialysis, as I said. And so emergency Medicaid is available to anybody. And it has been since the 1980s. And so that's how, for an uninsured patient who shows up in the emergency department with some complication related to kidney failure, they'd be able to get dialysis.
So the argument you were able to make for this policy change that you all sort of argued for in Colorado was, hey, look, we're going to pay for it one way or another, and we can have better patient outcomes and have it be more affordable if we allow access to scheduled dialysis spent at the state level. Is that accurate? How you did that?
Somewhat, yeah. So what?
Tell us more then.
Sure. So what the team found upon kind of looking for avenues to offer outpatient dialysis is that the criteria for an emergency at the federal level is really general. It's really broad. There's no specifics. It doesn't say, these conditions are covered. It just kind of says anything that might result in death, basically. And so there is a rule through the Office of Inspector General from the 1990s that states that states can add to this definition. So they can get more specific if they want. And it's actually a sub-regulatory change, like it doesn't involve legislation. And so certain states, a ton of states actually, including Massachusetts, where I am now, have added to this definition. And they can include whatever they think might be an emergency. So some of the things states have included have been, like, for example, COVID-19 care was added during COVID to allow patients to get oxygen when they leave the hospital. They declare COVID as an emergency condition. And that would allow for emergency Medicaid to then cover those conditions that the state has said. And so what the change was that they made in Colorado was adding end-stage kidney disease or kidney failure, same thing, as an emergency condition. And that allowed emergency Medicaid to pay for outpatient dialysis.
Yeah, so it sounds like there's this issue that you've been describing where you have these patchwork policies. The federal government has set some basic foundation where in emergency situations, dialysis can be provided. And as you've stated, at least my understanding is that if scheduled dialysis doesn't occur for people with end-stage kidney failure, emergency dialysis is a highly predictable thing. Am I correct? Like this is something that's going to happen for these people regardless.
Correct.
And the federal government then expects states to fill in the gap, or is this just not something that at a policy level the federal government makes any sort of has made any sort of statement about?
Oh, that actually is a kind of a complex question because it depends on the state. So that's actually something when we talk about how this policy change was made and how people can make this policy change in their states, it involves understanding how this cost is shared or split. So, for example, emergency Medicaid, it's federal money, but it also might include some state money. And sometimes institutions are paying part of it. So it really, really depends on the individual institution and state. In Colorado, I believe it was both federal and state that were paying, but it really depends. I should also say, like I've heard like in bigger states like Texas that have counties, sometimes the counties have a cost share as well.
Well, so from an implementation science standpoint, I think implementation science, its focus on policy change, in my opinion, has been a little bit spotty. But I'm really curious if you could talk a little bit about the path to policy change in Colorado. Tell us a little bit more about that, and how that was done in order to secure scheduled dialysis for undocumented immigrants, and how, in particular, I'm really curious how implementation science kind of played a role in that, if at all.
Sure. So I'd be happy to talk about that. And I should say this work was done before I came on board with Dr. Cervantes because the policy change had just been approved. So what I'm describing is her work and the work of her team. But I've now written a lot about it with her and I'm quite familiar with what happened. So essentially, there had been this practice of emergency dialysis for undocumented individuals. They were all admitted about once a week, and there was Dr. Cervantes was a hospitalist taking care of these patients, and one of the patients she became quite close with was quite similar to her in age, also had two young kids, but was undocumented and receiving dialysis. And this patient ended up not being able to work. She had multiple cardiac arrests from the high potassium that her children had to witness, and she ultimately decided to stop dialysis and passed away. And I bring up this story because this patient, Hilda, was the catalyst for all this policy change and deserves kind of mentioning. And so when she passed, Dr. Cervantes decided that this policy needed to change and started looking into it. And I would say first kind of just asked, can we make this policy change? And was told, like, you need to find the evidence and you need to be able to prove that this is a policy that needs to change. So she and her team started to collect data. And not only did they collect data, they started to involve stakeholders. And I think this is the part that was really important for the implementation science bit. We actually just I think we have a paper coming out, might be out by the time the podcast comes out, that used, like, retrospectively, we used PRISM to look at how this policy was changed because it basically was using an IS framework. They looked at the recipient characteristics, who were the patients getting affected, who were the clinicians getting affected, and kind of the payers, who was paying for this, and also like the financial officer, kind of all the layers of people who might be invested in a policy change, and started to build a coalition. And this really involved understanding, I think where IS really comes into this is IS provides a rigorous approach to multi-level context. And in this setting, it was important to consider all the people that would be affected by a policy change and explicitly looking at what people might not be on board and how we could convince them. And so this might include, for different states, it might include the chief financial officer. It might include the Medicaid officers in certain states. For example, Connecticut made a change like this. They involved the state Senate in their change. And so thinking of all of the levels, not just the politicians and the patients that would be affected, but all the different levels of recipients and their characteristics are important. And then thinking about, kind of using PRISM, thinking about the external and internal context. So thinking about kind of the policies that currently exist, who's benefiting from those policies, who's getting hurt by those policies, and how a change might affect those people, and how it would be, and then thinking about how it would be implemented and monitored. And so they had to go through and kind of look strategically at every level of how this policy change would affect people and who would be on board, who wouldn't be on board, and collecting information there. And what the team did was they paired this with research. So they've now kind of coined the term advocacy informed research for the kind of work that was done here. But they did several studies. The biggest one, which came out in 2017 in, I think, JAMA IM, looked at mortality and cost. And I think that was probably the most important for some of the policy stakeholders, Medicaid, the chief financial officer. They wanted to see, how is this going to affect our bottom line, which is money and patient mortality. And they demonstrated that this policy was deleterious to both. I think that it was like a 14 times higher mortality rate, but it was also 4 times as expensive to perform emergency dialysis. So that's pretty considerable in terms of showing outcomes. But they also did qualitative studies to show how patients and clinicians were affected, because I think they recognized something really important in the like looking at multi-level context, which was the clinicians. The clinicians were, especially the people taking care of these patients, when they interviewed them, they were really affected by burnout, by taking care of these patients that they knew they were providing substandard care, that the option for 3 times a week dialysis exists, but they couldn't get it. And burnout's important. Replacing a clinician is very expensive and time consuming. And so that's something also that they recognized that the invested parties in policy change might care about. And so I think where IS really came into this was doing this multi-level investigation of the different determinants and layers that might be affected by a policy change, and then making sure that they had research addressing those areas.
I really appreciate hearing that perspective, because I'm sort of thinking, like, how do you bring this to life, right? Does it imply that people might normally think about the patients and then go to politicians and say, look, these patients are suffering, and try to convince the politicians to make a change? And what you're saying is, hey, there's a lot more people involved at the administrative level, policy level, even at the intervention level, who are impacted by some of these policies, and whose stories and data from these folks might help help an argument for policy change. So the burnout is one example, the burnout of providers, seeing people week after week, knowing that they're just going to come back with negative outcomes. Can you maybe help our listeners with a few other examples of sort of key stakeholders who were either, for this kind of a change or who are against this kind of change, who maybe somebody might not naturally think of being as impacted by these policies?
Yeah, I think some key areas of people that you might not think would be affected. So one study they did was with the caregivers, which might just be the caregivers of these patients. And that was to kind of show how the caregivers actually had to take on the financial burden for these patients, because these patients were so sick, most of them weren't working, and then every like week they'd have to be admitted for a day. And so it meant that the caregivers had to not only be working but also be taking care of their loved one who is quite sick. And that has, long-term economic burden, meaning there's one person working in the household. And it also has burden for, they're also doing all the childcare. So there's childcare implications. And so that's just I think one example of an area that they researched that might not be traditionally a bottom line. So that's kind of like the patient side of it. But I think the other area was they aligned with community organizations and involved the community organizations expertise in doing policy work, but also involve them in some of the outreach. And so I think those groups you wouldn't necessarily think would have any stake in the game for a policy change such as this, but they are often able to connect the researchers and the community and the policy makers. So I think that they are really maybe an underrepresented area of how to make policy change. When you think about our classic kind of multi-level stakeholders, I think community groups might be connectors we haven't quite thought of.
Oh, yeah, it's really powerful to think about from the caregiver perspective, how much families might be impacted, both by having somebody who can't work, whereas maybe on scheduled dialysis, they could hold down a job and have an economic impact, but then that sort of them not being able to function sort of has a massive spillover effect. And also compelling to think about the argument about community agencies and community organizations being connectors that you might not normally think of in terms of helping implement policy change.
So, Katie, as you're talking about the importance of kind of personal stories, and you're also talking about the importance of data and advocating for this. My impression, and I'm no policy wonk, and I'm also not a person who's really been able to impact policy all that much. I'm a scientist and I'm convinced by data. But my impression is that policymakers are really, convinced by stories and by individual people, and that one person in the room with a story can be more powerful than data on 10,000 people. As I was preparing for this, I read one of several of Lily's papers, and I'm really taken by her paper called "Dialysis in the Undocumented: Driving Policy Change with Data," and in particular with the emphasis. The title being called "Driving Policy Change with Data," because I think about half of that paper really describes her experience that you were talking about earlier with Hilda, and it's a hard paper to read. There's a lot of compassion there. It brings a lot of emotion forward, and the data is also present. About half of it's there. And I'm just curious if you have, based on your experience, based on getting into this, if you have recommendations for implementation scientists who are hoping to impact policy change, who are working with policy makers. Like, is there a particular way to do this? Is this the right way where we bring up kind of individual persons and then kind of bring up the data? Or if you could just reflect on that a little bit.
Yeah, so I think something that's been really compelling about Dr. Cervantes' work, because I've seen her present this quite a bit and been involved in a lot of the papers, is that it starts with a story. I think that human beings are storytellers, and when you ever hear like politicians talk, they always talk about like, oh, I know I met somebody on the interview trail, and I feel like that's because they know that stories are powerful. And so starting with that story can really help the quantitative data and the data behind an argument that, to us scientists is really the crux of why you change policy. You change it for data to show a policy might help a group, and here's why, and here's the data showing that it would help. But I think stories can be quite powerful for the audience. So what Dr. Cervantes has often said when giving talks about like an advocacy blueprint is knowing what audience you're talking to. There are some audiences, like scientists, they want to hear the data, but there are other audiences, like patients, they might not care about the data as much as they care about hearing the stories. And policy makers who are not necessarily in healthcare or in science might be more compelled when it starts with a story. So Dr. Cervantes starts most of her talks on this policy change with the story of Hilda. And I think it's such an attention grabber and so poignant and powerful and filled with real, raw compassion that it helps frame the rest of the case. And so, what I would say to implementation scientists is there's a real importance to doing some qualitative data on how policy change might affect, the end user or multiple stakeholders, and using some of those quotes, using some of those stories to augment the power of the quantitative data can be really helpful for certain audiences. I think especially those who are not in science. And so that's kind of a key takeaway that I've learned watching this unfold.
A quick shout out to CIRC, the Society for Implementation Research Collaboration, for sponsoring that Implementation Science podcast and saving me from the torture of having to listen to my own voice while editing audio. CIRC brings together researchers, practitioners, and policymakers who are serious about reducing the research practice gap to much less than 16 and a half years, but who still manage to be genuinely lovely human beings. CIRC is also home to the premier journal, Implementation Research and Practice. If you want to join a group of smart people doing great implementation science, check out CIRC and consider becoming a member today.
Katie, I'm wondering if you could just tell us about the Navigate Kidney intervention.
Sure. So I've been involved with Navigate, but this again is Dr. Cervantes' trial. But I can talk a little bit about what it is and how it was adapted. So I was involved a lot in the adaptation bit and then in the evaluation. So Navigate is a community health worker intervention. I think the first that's been done with Latinos receiving dialysis. And the thought process behind this is that people on dialysis tend to have higher social needs, and this is especially true for Latinos. Issues with insurance, maybe immigration status, but also issues with transportation, employment, et cetera, et cetera. The list can go on and on. And because we know that patients who are receiving dialysis generally are disproportionately from a lower socioeconomic status and are often disproportionately minoritized. And so Navigate is a community health worker intervention where the main outcomes were focused on patient-driven outcomes that were identified from the patients themselves. The primary outcome in the study was intradialytic weight gain, which means on dialysis, you gain weight in between sessions because you're not peeing, right? So any fluid you drink, you just keep in your body until dialysis gets rid of it. And so patients are often encouraged to watch how much water and salt they eat, but often they don't know how. They're not really told how. They're not really told how to do this also in a way that matches their lifestyle or cultural diet. Like, for example, things like Meals on Wheels, they don't necessarily have Latino meals, and so they won't eat them. And so things like that can really make it very hard to manage their weight gain in between dialysis sessions. And so that was the primary outcome, which was kind of a surrogate marker for self-management, knowing how to watch your water and your salt. But they also looked at social needs and patient activation. And the reason that they did this is patients said early on in kind of their pre-implementation work that they were unable to do the self-management that they needed because they couldn't get food on the table. They couldn't get transportation. They couldn't get childcare. And that makes sense, right? If you think of like your hierarchy of needs, if you can't meet those basic needs, you're not going to focus on, your salt intake. You're going to focus on how we get food for your children first. And so the community health worker intervention aimed to address those things in addition to addressing education and help with managing their salt and water. And the last thing they looked at was patient activation, which is essentially just a marker of how involved a patient is in their healthcare. It's got a score called the patient activation measure. And they were looking at, did a community health worker help patients feel that they were more involved in their care? So, but all of those outcomes were chosen from the pre-implementation work where patients gave feedback on an earlier intervention that was focused on palliative care. And they said, we can't focus on palliative care because we need to focus on we need to put food on the table. And so they actually changed the outcomes because of this data. And so what they showed, the study just came out, I think last month, and they showed that patients who received a community health worker, I think they received about 6 visits in the dialysis unit, and the community health worker had a couple different things that they were doing: social needs, building trust with them, first of all, then social needs, then education about managing their diet. And they showed that the patients who received community health worker intervention had a significant intradialytic weight gain, like a significant improvement in intradialytic weight gain. But they also had improvement in patient activation, which is actually pretty hard to show. And so that to me was kind of a really cool part of the study, that the community health worker made patients feel more involved in their care.
Yeah, can you tell us about? I think you've already implied a lot about using qualitative information from participants and from sort of information from the folks that are sort of directly impacted. But tell us about how the ways you use tools from implementation science to do this specific adaptation for Latinos with kidney failure. Again, I think you've talked around some of those, but how did you use those tools, and what did you find that you needed to adapt for this population?
Sure. So, and I should say we just put out the manuscript on this. I think it came out in Kidney International Reports, and it was published at the same time as the study. But I should say we retroactively applied an adaptation framework, and we had to do this retroactively because adaptation frameworks are fairly new. And so this work started in the mid 2015, 2016, and we applied the ADAPT framework, which came out, I believe, in 2019. But it was what she did. And so if you look at the paper, there's like a nice little schematic. But essentially the first thing they did was look at a community health worker intervention that in Latinos for palliative care. The original kind of intent was palliative care to help patients with end-of-life decisions. And there was one that was more general called Apoyo con Cariño that was focused on non-dialysis, but Latinos. And so they first took this intervention and talked to, they created a community steering committee with Latinos receiving dialysis and asked the steering committee how they should adapt it for dialysis. In this adaptation, we used forms and functions to describe the changes that were made. The original paper actually uses very similar terminology, even though forms and functions, I believe, wasn't out at that time. They call them core elements, and then the activities that were used to inform the core elements. But to me, these are very similar terms. And so they identified the core elements of the original Apoyo con Cariño and then went to the steering committee and asked them what needed to be changed for dialysis populations, and kept most of the original functions, but changed some of the forms to better match what a dialysis patient might need. Then they ran a very small, like single arm trial, just looking at feasibility and acceptability for the same original outcome as the Apoyo con Cariño trial. But in some post hoc work that I believe is not published, they went back to the community steering committee as well as to the people in the trial and asked them what how they felt about the trial, what was acceptable about it, et cetera, and found that the patients said, "Oh, we really liked the trial, but we have trouble with transportation. Can the community health worker help with that?" And so they decided to change one of the functions to incorporate the social needs that just seem to be higher for the dialysis group in comparison to the non-dialysis group. One thing I'll say is, like, sometimes we're asked if it was culturally adapted. It didn't need to be culturally adapted because the original trial was with Latinos as well. So it was mainly just adapting it for dialysis. And these patients just are different. They often lower socioeconomic status, lower English proficiency, higher social needs than maybe the group that was in the original trial. And then after the single arm, they then adapted the forms and functions again. We also, at the same time, had done a study with clinicians in dialysis, the dialysis units. I was involved in that one, and found that a lot of the clinicians felt that language was really important, that these had to be, that language barriers really contributed to a lot of the social problems, like transportation. If you can't call the patient in their language, it's going to be hard to get them transportation, things like that. And so that feedback was incorporated as well, that qualitative study, into the changing the forms and functions again to better meet the needs of the Latinos on dialysis. And the main thing that they said between the single arm and the RCT was that they really felt the most distressing part about being on dialysis was not the end of life care. It was not knowing how to manage their diet. They wanted to be able to do something about their dialysis, and they felt they just didn't know how. And so they changed the forms and functions actually completely away from palliative care to focus on what the patient said, that they cared about self-management, and they wanted to know how to manage their salt and their water because that was the most distressing part of it. And so what also was kind of interesting about this adaptation approach was really adapting from qualitative work rather than quantitative work, because they had shown that it was feasible and acceptable. But then seeing that the patient said, "This is what's important to me," I think that actually was really important in why the Navigate final outcome was successful, because it was driven by patient feedback. So yeah, I hope I answered your question there.
Yeah, so it sounds like, one of the constants or one of the takeaways from this is that by really listening to patient feedback, you start figuring out what's important to them in this, not necessarily being what you would guess, and yet it seems like it has a knock-on benefit of probably making their overall health, outcomes better. So for example, you mentioned one of the goals was to, control intradialysis weight gain, which is largely, because of the self-care they had to do. And it turns out the self-care was hard and people really cared about that almost the access to dialysis and getting into dialysis, well, at least once that's solved, there's other things that emerge as being challenging that people really want agency around those things, which just if you maybe had just focused on let's get people to dialysis and then, assume that everything else is going to go fine, maybe you're going to, the outcomes are not going to be as good. Maybe you'll lose people in the system. I don't know. I mean, I guess maybe you could envision for us, like, what do you think these folks' lives would look like if you didn't have these community healthcare workers, in their lives, if they didn't have this intervention? What would it look like?
Well, I think one thing I didn't mention here that I also think is important, because yes, it was changed for patient outcomes, but we always have to think about, like, do the funders care? What would drive them wanting to fund a study like this? And it's very well known that high intradialytic weight gains lead to higher hospitalizations and have a higher risk of mortality. So that's like already known. So I should say that, that's always in all our applications is we already know intradialytic weight gain is bad, but it turns out patients care about it too. So if we didn't have a community health worker helping with self-management, what's the alternative? So right now, most dialysis units, most of them have a dietitian, and most of them are getting a little bit of information, but it's not necessarily tailored to the culture, language, and like health and numeracy literacy of the individual. So what they found in this study, for example, is like a lot of these patients, some of them can't read, and a lot of them didn't understand like the water bottles and how much water to drink. And so that's where the community health worker could really make like that was one of the forms of like how they were going to achieve their functions of self-management. A lot of them talked about how the community health worker motivated them. She made them feel like they could do it, and then they felt motivated and they felt more empowered to try this. And so without, just giving someone a sheet of paper and walking away might not empower someone to take care of their health in the same way that someone following up with you who cares about you will. And so without doing it, I think they would receive standard education. But what they showed is the people who didn't receive it had higher intradialytic weight gains, which is all sorts of deleterious clinical outcomes.
Right. So like the dialysis doesn't just get rid of the weight gain, right? It's not like you get higher weight gain, but then it pulls it away. It sounds like there's a known sequela of bad things when people are cycling bigger in between sessions. So addressing that self-care, that management, bringing down the intradialytic weight gain has lots of knock-on benefits.
Mm-hmm.
It also sounds like you're implying, I mean, at least I'm thinking if I was a patient talking to a doctor and I just didn't understand what I was supposed to do, there can be a lot of shame and a lot of challenges with that. And that could demotivate somebody if like, I could see myself reacting, I don't want to forget it. I don't even want to figure this out. So even though, as you're sort of saying, if people are given standard care, sometimes maybe that standard training information, maybe that's not sufficient for some folks. And it may be hard for the healthcare worker to know. So it sounds like these community healthcare workers are really adding a lot of benefits in terms of education and support. And like you're saying, sort of additional motivation to help people get the agency they need to.
Yes, 100%. That was I think the first form was building trust with the participant to make them feel like you were kind of supporting them first before trying to get them to do what you want them to do. But I also think understanding the needs of the individuals, and I'll just like give an example. Sometimes I've had patients who I'll say, "Oh, you need to eat a low salt diet." And they're like, "Well, I live on the streets and I eat all my meals at 7-Eleven." So that's very hard to tell you to eat a low salt diet if I'm not taking care of your basic needs. And so having a community health worker who can do those wraparound parts. Oh, well, here's the places at 7-Eleven that have lower sodium. Like she can do things. She was doing things like that, the two community health workers, in a way that you can't do with just giving someone a piece of paper.
Yeah, I think we expect an awful lot of the community health workers in terms of their provision of kind of adjunctive interventions that help support people getting to, I guess, more kind of professionally based treatment options, as well as doing direct interventions themselves, and really translating, I think, too, between the professional interventions, the professional recommendations, and what's actually feasible within that individual's life. This is fascinating. Such an interesting intervention. I'm really curious, as somebody who's been doing both development intervention research and policy work, whether you personally feel that implementation science as a field broadly writ has given enough attention to policy change as an implementation strategy.
This is a really great question. We actually last week in our IS fellowship were discussing this about where does policy fit in. And I think, when you look at the literature on policy and IS, there's actually a fair amount of literature going back a number of years, like 10 years or so. So it has been discussed, but I think there's still a lot of debate, like where does policy fit in? And especially, is it a strategy? Is it the thing? Is it the intervention? What is it? And we discussed this a lot last week, and my takeaway was it depends on how you define it. And so I think implementation science can add a lot to policy change work. It adds rigor, adds, I think, like using frameworks and thinking carefully about the strategies and defining them is really, really important. We work with through the American Society of Nephrology. I work with a group that helps people throughout the country who want to make this change, and the majority of them are not researchers or implementation scientists. So I also think that there's something here that adds rigor for people who maybe aren't as comfortable with IS, but it would really help them to think through the multi-level people that need to be changed. Like you can't just say, oh, this needs to be changed because I want it to be changed. Like you have to think through every single level, what their perspectives are, their characteristics, what's the inner and outer context. And that's where I think IS can be truly, really helpful in providing kind of the framework. And then I think it can also be helpful in defining what your outcomes would be from the policy change. Really thinking through not just, oh, if we have Medicaid expansion, how many more people will get insurance, but how do we sustain it? Sustainment is a really important part of policy. And I think where IS is also helpful is everything in IS is iterative. So then you go in and go back to the beginning, and now we're going to study, the context, the determinants of now the policies in place. Well, how is it being done? Actually, I will say in the policy change they made in Colorado, they had to have a mechanism to show that they were watching the change, that they were watching the cost, that they were watching the number of patients. And so that's important for sustainment. Is this policy sustainable? Like we have so many policies that are there for a year and then they're gone. And so if we really want to make long lasting impact, that's where I think it can be really helpful to include IS methods.
All right. Well, thank you so much for that. Now we're going to launch into our game. And today we're going to play a little personality test. It's the modern personality test for our era, which is the Would You Rather game. And so I'm going to ask you a couple of questions, and I want you to tell me, which of these two things you've played Would You Rather before, right?
Of course.
Yeah, of course. All right. All right. Would you rather change the world using science, but be a terrible person to work with, or have little impact with your science that you're conducting, but everyone loves working with you?
Oh, I think the second one.
Tell me more about that. Why?
I just think at the end of the day, the success is kind of fleeting, but people will remember, that there's that quote of like, people remember how they feel. And being a good person, I think would make me feel better at the end of my life than having a lot of success, even though it means that there would be less change in the world.
Okay, unfortunately, that's the wrong answer. The correct answer is change the world with science, but be a terrible person to work with. But let's go on to the next round. Would you rather do rigorous and reliable work that nobody cites, or do shoddy and unreliable work that makes you famous?
I feel this is a trick question. I think the first one, just because at the end of the day, it's your name, right? Like you have to be comfortable with the work you're doing. So, you can always cite yourself. Someone will cite it.
That's true. Self-citation is the way out of the no citation graveyard. I always like to think rigorous and reliable that nobody cites. That's my bread and butter. Also, rigorous and reliable work where you find nothing. Absolute. That's the last 10 years of my career. It's awesome. You should join us.
Good company.
Here's one. So I might know the answer to this one already. I'm not sure. But would you rather have a major impact on public policy or a major impact on the way research is conducted?
I might be a bad implementation scientist by saying this, but I think I would choose policy. I think methods are also really important about how research is conducted. And I also think these things are kind of linked. But I think policy has always been a really important part of my work and Lily's work. And so I would say policy would be more important to me.
It's the beauty of the Would You Rather is it presents an impossible choice between two not real alternatives.
Yeah.
But, highlights your personality.
All right. If you couldn't be a nephrologist, and I have to qualify this by saying my wife is a nurse practitioner and she's worked in both urology and radiology. And she always tells me that she thinks the nephrologists are the absolute smartest, kind of doctor because of the complex things you have to know about how the human body and the kidneys work. So it comes from a place of great admiration. But say, you didn't match at a nephrology residency and you could go back in time. Would you rather go downstairs and work in urology, or would you rather go upstairs and work in neurology?
Really hard. Okay, I would say neurology because urologists are also surgeons, and I hated the OR. I just was like, I cannot work in the OR. So I think what's similar about neurology and nephrology is it's mostly a thinking specialty, not using my hands. And I just don't think I belong in the OR ever.
That's great. From my experience being around urologists, the only thing or the best thing that come out of that profession with is incredible stories about the kinds of things that happen to people's bladders and urethras, and not appropriate for podcast or the dinner table, but but absolutely fascinating.
What do you think, Kevin? What score does Katie get?
Oh, geez. Well, I would say she gets a very high score on the integrity and social justice orientation.
Overrated. Overrated.
Yeah. Yeah. Well, this is a personality test. So if we're going to, rate her high, I think we'd rate her high in conscientiousness, I guess, if we're using a big five framework, and low on motor dexterity.
Yeah.
Or at least claimed, the desire to use motor dexterity in our work.
Well, Katie, we always ask our interviewees to list one or two articles that they think are really essential for implementation scientists, budding implementation scientists, or those established in the field. What are some of your favorite articles that we should disseminate?
Sure. I want to give a shout out to whoever created our suggested reading list for our fellowship, because I went back and looked at it, because those are kind of like what our fellowship considers the key essentials. So one that we use a lot, we're running a grant workshop right now that we use in the grant workshop, is the Proctor 2012 manuscript called Writing Implementation Research Grant Proposals, 10 Key Ingredients. That one is just kind of like an outline of the things that should be included in IS grants. And I still think IS grants just aren't that common. There are a lot of people that aren't used to reading them. If you get like the wrong reviewer, they might not understand it. And so it can just be a really helpful framework. And so we use that one a lot. So I feel like I kind of have to say that one. Personally, I would say the resource I use the most in both our consults and then just for myself is it's on the UW website. There's like a list of all the different theories, models, and frameworks and the categories they fall into. It's just very helpful to explaining theories, models, and frameworks. And it comes from a paper, I think it's Nilsson, Implementation Science from 2015, making sense of implementation theories, models, and frameworks. So I think that graphic came from that Nilsson paper. But I tend to use that a lot when I'm not sure which framework to use. I'll kind of look back at it to kind of categorize the framework I think I want to use and where it fits in.
Kevin, do you want to ask the last question?
I prefer the awkward silence, but sure, I can do that. Do you have any shout outs, people you want to connect with, and how can our listeners connect with you?
Oh, sure. So I think I have to shout out Lily because this is all of her work. And she's been an incredible mentor. And I think we also have to give a shout out to her kind of right-hand person, Claudia Camacho, who is her first community health worker and and I think was kind of the magic behind a lot of the Navigate Kidney trial. And then as far as how people can connect with me, I wish I could say I use X, but I got logged out and I can't get logged back in. So maybe not X, but certainly by
Wait. I'm sure that your focus is on undocumented immigrants has absolutely nothing to do with the fact that you got logged out and can't get back into the X. Just a coincidence.
I don't know if this is an accident. Might be a conspiracy. But certainly you can email me and I would love to connect with anybody. And I also, if I'm giving shout outs, I mean, anybody who works in the policy space in IS. So there are many people I know, for example, Erica Crable, maybe that could be a shout out of someone I've never met, but would like to meet because she just does so much work on implementation science and policy. So did I answer the question?
Yeah, that's great. Yes, there's no wrong answer to that one, unlike some of the would you rathers.
All right. Thank you so much, Katie. This was absolutely fascinating discussion. I fully expect that all three of us will now get doxxed online by some right-wing activists, but that's the risk that we have to take for doing a podcast. But we really appreciate having you on the show.
Yeah, thank you for the invitation. It was great to answer
It was a
these
real
questions.
pleasure hearing about the work you're doing.
Yeah, thank you.
Thanks so much for listening. I hope you enjoyed today's show. You can reach Kevin on Blue Sky at Kevin M. King. All the comments and opinions expressed during today's show are our own. They are well-reasoned and insightful, and therefore are probably not endorsed by our grant funders or employers. Thanks for listening. We'll catch you next time.
Wait. I'm sure that your focus is on undocumented immigrants has absolutely nothing to do with the fact that you got logged out and can't get back into the X. Just a coincidence.
I don't know if this is an accident. Might be a conspiracy.